Niky, may I begin? Good afternoon, everyone. My name is Richard Brown. I'm the chair of the Open UK organisation, the half of the Epilepsy12 Open UK conference team, and very glad to be with you today and shall be co-chairing the afternoon session with Colin Dunkley. Now, Colin won't be introducing this particular session because he's in it. So it's my great pleasure to welcome fantastic colleagues, Colin Dunkley and Niky Raja, who run and deliver the Epilepsy12 national audit, which is measuring the care we deliver and thus improving it. And it behoves us all to use their data to improve the care that we deliver to the children and young people we serve. So without further ado, over to Colin and Niky.
Thanks, Richard. Nice to be with you in the room and also online. We're going to do this as a double act, so I'm going to go first, and Niky's going to do a bit, and then I'm going to finish off. And for those of you who don't know me, I'm a paediatrician based in the Midlands, and then have the privilege to help with the Epilepsy12 audit. So predominantly, this talk is going to be around Epilepsy12 and what's been going on in that space. So I don't know what sort of summer you've had, but I'm going to start this by deliberately misquoting the Beach Boys. And I think there's quite a lot to be positive about going on. And I think a lot of it's around connecting and connections that may be in unusual directions. So that's the sort of theme I'm going to try and weave through these minutes I've got with you. So we're going to look at connections to improvement and what's in our latest results. Niky's going to show you some of the updates in the platform and in some of our dashboard outputs. I'm going to look at a bit more which Helen Cross gave you a glimpse of, the long view, and I'll try and go a little bit longer actually than Helen gave you a sneak look at. And we'll connect you to what's coming up, hopefully. So that's the plan. So I've great fun updating this each year, and this is our timeline since we began in 2009, and we've moved into an annual rhythm. So the bottom line shows the outputs in terms of reports that now come out on a yearly basis. And the results I'm going to show you today are from our latest report. And audit can be a bit dry and number-based, so we always have, more recently, great satisfaction trying to show something that contrasts with the sort of dry numbers side. So this is a picture from an artist of someone living with an epilepsy, and we think it captures quite a lot of what goes on in epilepsy and the richness that is really in those numbers. So the numbers I'm going to show you from today are for cohort 6, and we published these numbers a few months back now in July. And just to remind you, when we produce our reports, it's a mixture of clinical audit and organisational audit. And the children we're trying to see signal from those who've got newly diagnosed epilepsy, and they've had a first paediatric assessment within a given year. And the way it plays out is that they present in one way or another to a paediatric service over a year's period. Then they have another year where care is delivered, and then we capture the data that comes from their story, and we go through an analysis and reporting phase. So that's the cycle for each cohort, and obviously we're doing that year on year on year, so there's a whole overlapping sequential nature to our audit now. And then in the middle of that journey, we take a snapshot, we take an organisational picture of what their service looks like, and then the wider landscape for epilepsy across England and Wales. And then we conflate all that and try and make sense of it in our annual report as one of our outputs. We do lots of other outputs as well. So the numbers I'm going to show you are from our latest report, and we were really pleased to have the biggest numbers we've ever had, almost 50% bigger than previous cohort size. So we had over 3,000 children and young people, and they came from services around England, Wales, 120 services altogether. And what's interesting when you look year on year is how remarkably similar each cohort is to the previous cohorts in terms of demographics. So similar to previous cohorts, we had slightly more males than females, and we had, as you would expect, a high preponderance of neurodevelopmental comorbidities in our mix. And this is a nice graph showing age distribution. So it shows males on the right, females on the left, and shows the number of children and young people at each age up and down the age range. And it's surprisingly uniform, actually, through all the different ages up to 16, and then we get a bit of drop-off as people get to more traditional adult-based services. But that's our population. And increasingly, we're interested in other characteristics of our patient group. And this gives you the breakdown as seen through Epilepsy12 of the ethnicity groups within our cohort. And we're interested in this not just from a demographic point of view, but increasingly interested in whether characteristics such as ethnicity affect your quality of care and your patient journey. And this is beginning to be a direction of travel for the audit. This is a bit more data on the numbers of children, not just with neurodevelopmental problems, but also with the comorbidity of mental health. And again, we're increasingly interested on not just how we look after people with their seizures, but on how we look after their other comorbidities that actually may be more of an issue for them than the seizures themselves. So you can see in the epilepsy long-term condition, there's really high levels of comorbidity compared to other traditional comorbidity, traditional long-term conditions, and we see that in our demographic data. And then we're also interested in the home context, the community context, the neighbourhood context that the person's living through. And we've shown this type of distribution before, but it's always worth showing. And this shows by postcode the deprivation score that person's home is based in. And we know already that epilepsy is overrepresented in those from a lower deprivation score. So you can see that in the England-Wales level data at the top. What's quite striking is region by region how much variation there is in the prevalence of epilepsy from different deprivation quintiles. So it's really striking, and you can definitely see a north-south difference there when you look at the preponderance of those from the lower deprivation quintiles. Higher. I always get confused from the higher deprivation quintiles. So I'll walk through some of these results in a bit more detail, but this is a typical summary view we give of our annual performance indicators. And we say there's 10, but there's always really 12. So there's 12 performance indicators because some of them have a secondary element. And the pale lilac is the latest cohort, and the dark purple is the year before. So you can see a little bit of difference between the two cohorts, even on this view. So if we were doing really well and everywhere was as it should be, then all these bars would be at 100%. And so you can see just generally there's still a lot of work to go. work to do. But don't be too depressed, because what you'll know we do is, over the years, we push and sort of stretch the agenda. So there's quite a lot of measures that we don't look at anymore because we've done quite well. So things like carbamazepine in genetic generalized epilepsy, misdiagnosis, and other bits and pieces. We've done well in those areas, so they've stopped being in our priority KPIs. And some of these we've made even more difficult to fulfill. So we've introduced things like timeliness into the MRI and seeing a paediatrician with expertise. So although the gap is still very prevalent, there's definitely a lot of improvement to see year on year. And you'll see that when we take the long view a little bit later. So I'll just pull out some of these results for you in a bit more detail. And the way I'm going to do that is I'm going to take the results that appeared in our State of the Nation report. The results go through a co-analysis type process. So we try and look at all the data, and then we pull out the story, the narrative that we think is coming from all the data. So these are the numbers that appeared in our report, and then I'll show you the recommendations that went with them. So under the theme of contributing and participating, we were delighted in the amount of participation we had this year. We would like every service to take part. We think there's 150 services in England and Wales who could potentially take part. We had 120 take part in the clinical side, and just less than that in the organisational side. But the number of children who we ended up looking at with epilepsy was 3,105, and you'll see in a bit how much of an increase that is. And with the latter rounds of Epilepsy12, you'll know we're now just capturing those kids with epilepsy. So all those children had newly diagnosed epilepsy in our year of interest. So some of the numbers under this theme. Putting data into Epilepsy12 is easier than it used to be, but it still takes time. And we've been trying to make it easier to take part. We've been trying to push for job planned time to lead and job planned time to do quality improvement. And this year we showed what's out there in terms of formalised job plan time for QI and leadership. And you can see there's a little bit out there. So 40% of trusts had nothing in terms of quality improvement, and 35% had nothing in terms of leadership. But that means there was a little bit out there, but we think it's inadequate for both quality improvement and leadership. So these numbers give us something to look at and think about as we try and grow the case for audit and quality improvement and service leadership. So we made specific recommendations around that that falls on trusts and those in commissioning to think about how do you help those leading and supporting a service improve that service and grow it in the direction that the children and young people need. This is beginning to take words that you'll see familiar within the 10-year plan, which I'll talk to in a little bit. But some of our data points to the need to build community and neighbourhood provision for children and young people. And we were really pleased to see improvement in the number of children with core care planning elements increase. So just over 2/3 had evidence of all the core care elements of their needs achieved. There's still some work to be done in the SUDEP. So a year or so ago, we started obliging some type of discussion or risk assessment for SUDEP. And you'll see in the elements that fulfill the overall core elements, SUDEP is still the lowest in terms of the thing we could improve most, I think, across the board. So that came in at just less than 70% of children having a SUDEP element. This was really pleasing to see. This is children in school as seen from the lens of health. What percentage had an individual healthcare plan for school around their epilepsy, and this increased substantially. This year it was 67%, so went from about a third to 2/3. Transitions, one of the 4 deliverables in the NHS England plan. There's quite a lot going on transition-wise, but I think it's not particularly commissioned or supported or understand what good looks like. There's lots of different practice across England and Wales, but there is definitely things happening in that space. So most services have a referral pathway to adult services. Most are using structured transition resources. You heard about the Hull exemplar, you heard about Ready, Steady, Go. There's other exemplars out there. And a lot of services are doing dual supported services, so clinics where there's both representation from adult and paediatric services together, which I think is the ideal model for some elements of young people's service transition and handover. This gives you a flavour about how that joint working looks over England and Wales, and you can see that some services have a single joint appointment, some have a mixture of joint and individual collaborative type pathways, and some have several joint appointments. So I'm not sure what best is or what optimum is, but you can see there's a mix. So some type of blend of adult and paediatrics, I think, is needed. So using the language of the 10-year plan, we made recommendations around neighbourhood provision. We talked about steps to improve the use of passports and mental health screening and self-management and PREMs and PROMs, and all these things we think are going to be partly solved by the emergence of digital solutions. It's challenging for the children with epilepsy to see a paediatrician with expertise in the first year in a timely way, particularly with a 2-week challenge. So we introduced not only the 2-week challenge a couple of years ago, but this year we made it even more difficult in that we said that the input had to be direct. So it couldn't just be one paediatrician talking to the paediatrician with expertise in a room somewhere. The input from the paediatrician with expertise had to be directed at the child and young person and family, either could be face-to-face or virtual, but it had to be direct input. So this percentage decreased a little bit, but it's still, we were achieving it in 2 weeks. So we take any paediatric interaction as the first time point, and then within 2 weeks of that, we take the second time point. So we use a slightly different definition of 2 weeks, but it makes it easier to measure in the thick of it. So we were achieving that in 50% of children. So you can see how much work's going to need to be done if we want to get that closer to 100%. You can see that most trusts have the median is 2.2 paediatricians with expertise per trust or health board. So there's definitely more specialist epilepsy nurses. There's more children and young people seeing an epilepsy specialist nurse, but the needs of young people are increasingly recognised, and so I think we're still going to need much more epilepsy specialist provision. But you'll know that the number of children benefiting from epilepsy specialist nurse is definitely on the up. How many epilepsy nurses do we need for each trust, for each health board? We don't know, but it's definitely more than we've got at the moment. And this is how provision looks when you have along the y-axis the percentage of children for that service who have input from a specialist nurse within 1 year. And then each vertical bar is a separate health board and trust. So you can see towards the right, all the children in those services have got access to an epilepsy specialist nurse, and then there's a fall off with some trusts, zero input, and just some of the children have input. So although the overall percentage is high, it's definitely skewed towards some trusts who are really struggling in this area. We are reporting now outliers. So those are trusts and health boards who, against certain parameters, are statistically outside what would be expected. So specialist nurse provision is one of those things we've tried to target with an outlier process. And this is the same data you've just seen, but now spread out over a funnel plot. And as you go to the right of the axis, the size of the service gets bigger, the size of the cohort. So this allows you a statistical mean of seeing whether variation is just because you're looking at small numbers or whether there's a statistically significant difference. And you can see those towards the top of the graph are positive outliers, so they're all getting 100% against the mean. And then there's a few down towards the bottom who are negative outliers. This is quite a powerful way for us to draw attention to trusts and health boards who need support to improve epilepsy nurse provision. But you can see it's quite a polarised non-normal distribution, so there's quite a lot who are doing well, and then there's a few stragglers. You heard from Helen a little bit earlier about the gap around tertiary input and also children who should have a epilepsy surgery referral but who are not having that. So I think there's still room to improve here. There's been a bit of improvement in the epilepsy surgery results, but there's still a long way to go here. And this is what the same type of funnel plot looks like for the other outlier we have around tertiary input. And you can see this is much more normally distributed. So there's much more of a spread around those who are doing really well at referring to their tertiary colleagues and those who are struggling. So there's a real mixed picture across England and Wales around this. So we've begun to do some work with NHS England particularly to try and understand the issues that Helen was talking about earlier. Why is the unmet need in terms of tertiary referral and epilepsy surgery referral? And I think it's a mixture of flow issues and capacity issues, but we're just trying to tease that out with some of the data that Helen shared and some of the Epilepsy12 data. Mental health. Thank you to the young people for putting mental health on the agenda and talking to it right from the offset of today. Things are getting a little bit better, but they've got a long way to go. So although our KPIs show that we're doing more screening and we're referring some children for support, there's a load of children with mental health problems we're not even identifying, let alone referring on for support. So our KPIs could falsely mislead you, but you have to look at the numbers involved. There's very small numbers really who are having identified mental health issues identified and supported. We've been pushing for a formalised routine screening, and this is just to show some of the data we have around the types of screening tool that are being used. So you can see that SDQs are being used in 16 services, but there's a few other tools out there. So there's a range of approaches that can be taken. So hopefully we'll see these types of approaches increasing dramatically. We need help with that, of course. So recommendation 5 was around that. We've had 7 pilots supported by NHS England over the last year or so. We need to now turn those into embedded, ongoing, sustainable solutions that grow and improve and get us closer to an increasing evidence base. there's a lot of work to do in this space. I thought I'd just briefly, before I hand over to Niky, just show you the other things that may be of interest that comes from our epilepsy data. We tend to focus on quality, but there's a wealth of data in there. So these are just some quick summaries of the types of things that is in there that you might be interested about. So this is just simply counting the rates of epilepsy syndrome diagnosis among the 3,000 children with epilepsy and seeing what the top 10 are. And you see the commonest is no syndrome, but then next is childhood absence epilepsy, 228 children. Select self-limited epilepsy with central temporal spikes comes next. And then the 3 juvenile epilepsies, so JAE, JME, and epilepsy with tonic-clonic seizures, are fairly even in the league table. And then we go down to the less common epilepsy syndromes. So you can begin to see what you probably feel in your secondary clinic about the rates you see, but you can see at national level how those stack up. And similarly, you can see this is just 1 year's worth of epilepsy drug prescribing, and you can see how far ahead levetiracetam is in terms of usage. And then lamotrigine, valproate, ethosuximide, carbamazepine, clobazam, vigabatrin. And we can obviously look for trends in this over time, but at the moment this is just a one-year view. And most of the interest in prescribing has been around sodium valproate, and this is our latest output in terms of sodium valproate prescribing in the first year. And we'll be interested to see how this changes over the next few years as the MRHA guidance kicks in. You can see there's definitely a male versus female imbalance, and there's a fall off, as you'd expect, as females go into the second decade of their life. So where will we be in 2, 3, 4 years' time? It'll be interesting to see. So that's enough of me. I'm going to hand over to Niky now.
Yeah, so this is just one slide to know that in addition to our annual report findings, HQIP, who are commissioners, did a little news article just to spotlight our findings from this year and made a specific focus on the school healthcare plans, and a kind of increase can be credited to lots of people and lots of work going on. So please do look at that if you haven't already. And then I was just going to run through a bit of our reporting in the audit and our different outputs that Colin's alluded to already. So we have our annual report, which is 10 pages now, a little summary report highlighting the key findings, and then national recommendations made of those, which Colin's just run through. And then in addition to that, we have extended analyses for the clinical and organisational work, and that allows a bit more of a deep dive at a national and regional level that goes a bit beyond just the key performance indicators. And this year and last year, I think we've tried to build in more subgroup reporting, so not just kind of if you've achieved the KPI at geographical level, so regional, national, but also breaking that down by age, gender, ethnicity, deprivation, and then as well as the presence and absence of neurodevelopmental conditions and also mental health conditions. So it's trying to see how achievement of KPI and then quality of care varies by those different population groups. We provide local results to health boards and trusts, and that gives them the same data that's in the extended analyses, but for their local services, allows them to benchmark themselves against the regional and national averages. We have data files as well published online, just so people can access the data in different ways and use that further if they wish to. Do the outlier reporting that Colin mentioned as well, and all those results are online, so that's the positive and negative outliers for each of the measures. We provide NHS England with some bespoke data packs that gives them from Health Board and Trust up to England level data, and then that gets distributed by them to each of the regions and ICBs, and that has a focus on the key areas of care within the bundle care document. But the two that I'm going to focus on now is our monthly dashboard and then our live dashboards as well. So firstly, this is our frequent reporting dashboard that's available on our website, so anyone can access this. And what we focus on is our 10/12 KPIs and reporting them at the 6 levels of geography, which you can see on the left-hand side, so right from England and Wales National to Health Board and Trust at the lowest level. And we refresh the data every month, so it's just directly from our platform when people are entering data throughout the year. And then when we reach the end of the year, we'll take that snapshot and use that for our annual reporting and annual report analysis. So some new things that we've introduced recently is that you can now select the cohort that you're interested in. So we've just looked at cohort 6 data, which is the latest annual report, but we're already collecting cohort 7 data, so you can have a kind of sneak preview of the KPIs there and look at that throughout the year, building up to next year's report. But you can then look back at cohort 6 and cohort 5, and you can still retain all of that data at all the levels. And then on the top right, you can see a data completeness graph. So that gives you at a national view, so England and Wales combined, the number of cases and case records that have been submitted on our platform or completed compared to all of those that have been registered onto the platform. So we'd want kind of all the bars to be the same so that we have complete data completeness ahead of our annual report. And then in 2023, we launched a new data collection platform. So it's for services to go on and enter data for the audit. And our aim with that platform was to reduce the data entry burden for participating in the audit. So we focused our case ascertainment, so we're only collecting data on patients with confirmed epilepsy and looking at a first year of care as usual. We minimised the data set, so got rid of a lot of questions and tried to make all of them kind of yes or no and minimise the free text, speed up data entry. And it's just a whizzier platform, so it's easier to use, hopefully, and it means that data entry is easier. So there's just a few snapshots from our platform. You can see a cohort view. You can look at your different cohorts on there. And then you get some graphs that show you how many completed patient records you've got, so you can monitor that and hopefully get that up to 100% before the annual deadline. You can see your distribution of your cohort, and then there's also a map that you can see, for example, for London, each of those pink dots is a patient, so you can see kind of where your patients live and could help you if there's trouble getting to clinic, etc. So see a lot. Then within each patient record, you get a view, which is on the left-hand side, of all the different sections of the record to complete data entry for. And it lets you see your progress and which bits you've completed, which can be really helpful in helping you enter more data. But then each record will have a performance summary that you can see on the right-hand side just for a dummy patient. And you can see for each of the KPIs if they've achieved that or not. And this can be really helpful in helping you enter correct data. So if you notice on there that person for this one, they haven't had an MRI within 6 weeks, which you can see by the little blue triangle, and you believe that they have, you can go back and correct that data. So it will really help us get a complete picture at the end of the year and improve data quality. But also if you spot this before the first year is up, you can also intervene and potentially rectify that and improve patient care. So all of those patient performance summaries will aggregate up to this live real-time dashboard that you get within the platform. And that will show you where you are on your KPIs right from local level compared to the national. And this updates in real time every time a patient record is updated, so you get this information straight away. The other thing that you'll notice on there, sorry, it's a bit small, but hopefully you can get the idea, that below trust you get something that we've called organisation, and that's essentially just what we've labelled as a sub-trust level. I know there's lots of mergers that happen, so you're one larger trust, but your hospital sites or clinic teams might be very different. And although we're still only able to report in the public domain at trust level, it means that you can view this data and look a bit more in depth, so it can help local quality improvement. So then our next steps, which is something we're building very early on, but we're hoping we'll be able to launch soon to everyone, is a report builder, but you can kind of think about it as a filtering system. So if you look at that, this is all dummy data as well. If you log in as a clinician and you go onto your report builder, you'll see you have 443 cases there. You can search if you need to find like a specific patient, but then you can filter by demographics. So if you can select if you just want to see all the female patients or just ones of those particular ethnic group or deprivation quintile, and the list will filter and shorten just to give you those that meet the criteria. So for example, you have the demographic filters, but you also have these additional ones, which hopefully you can see, but you can select the cohort, if they've had their record completed or not, and then if they've achieved each of the KPIs, and if they have a comorbidity condition. And then just an example, if you were to select the filters, and you can see that coming up as the active filters. So I've just selected cohort 6, they've completed the audit record and they haven't achieved KPI 2. It gives me those 5 cases. And then you can go into the case records straight away by that action column at the end and either edit the information, or hopefully you can spot that they haven't achieved that, they haven't seen a nurse in this example, and then you can correct that. So this might work, but I've just got a bit of a video of just explaining what I've just kind of run through, but showing you how it will work in real time. So hopefully it'll go down and you can see, you can just select on each of the filters that you want, and then that large list of patients will shrink down to only those that meet certain criteria. And you've just got the 26 now that are in cohort 6, so you can hone in on that. Those are the KPIs not achieved in this instance, so we can just look at KPI 2 and then it should shrink the list down. It's just a little bit slow at the moment, so we've got a few bugs to resolve before we can push this to everyone, but we hope it will be useful for people to help look at their cases and improve data quality, improve patient care. Even in the dummy data. I think that is done. Let me move on to the next. Yes.
The data people and coders within the college are amazing. I don't know how they do all this. Things just happen. I'm going to look back now and give you a longitudinal view. So we've been going 15 years now, and traditionally we tend to present our data year on year, but obviously you can go back. And Anjali and team have done this lovely piece of work which we presented in Lisbon and Bournemouth recently, showing improvements by looking longitudinally at data over 15 years. And what we did was we looked at all cohorts so far, and we said what of the key performance indicators can we apply to each of the cohorts, and then what's changed over time. And just for today, I'm just going to show you this at national level. So this is England, Wales, epilepsy, all combined. So first of all, in terms of our cohort size, this is the number of children in each cohort since we began in 2009. So you can see when we started, we ran it as a pilot really. So we had a very small number, but year on year, the number's been increasing, and you can see the big uptick in numbers this year. And then this is the slide that Helen showed you a little bit earlier. This is applying full KPIs as far back as possible, and we could do full KPIs where we define the denominator and the numerator back to 2017, and you can see there's incremental improvement in everything except for tertiary input and epilepsy surgery, maybe a little bit, and then paediatrician with expertise is increasing, but we had a dip this year because we changed our goalposts a little bit. So that's a welcome dip because we're stretching the ambition. But we were able to go even further back by restricting our KPIs where the whole epilepsy cohort was the denominator. So you can see even more marked improvement in some areas when you go back to the beginning. So there's been big increases in access to paediatrician with expertise, to epilepsy specialist nurse provision, ECG and MRI, but still stasis in terms of for those with complex epilepsy having access to paediatric neurology. So why is that? What's going on there? That's looking back, and now finally just to look forward. So the NHS plan, if you've read it, you might, if you did what I did and put epilepsy in and did a keyword search, you'd be quite disappointed because it's not mentioned at all. That's the first thing I did. It's no mention at all. But if you pick out the themes and think how are we doing epilepsy, how are we trying to improve epilepsy, there's quite a lot in there that actually resonates with what we're trying to do. We just need to think a bit differently. So I think there's a lot of things we can jump on to help our ambition for epilepsy over the next 10 years. So there's loads of impact we can reduce in epilepsy if we start thinking in terms of prevention, if we get upstream, if we think about precision medicine. There's loads of care we can deliver outside the hospital walls. We need to think about how do we reach people in their real lives outside clinic. How do we use digital to do this? What's a single patient record look like for someone with epilepsy? How could they best interact with the NHS app? How can we harness equitable care so there's not just geographical equality, but there's equality for other attributes? How do we do that for our population where there's particular risks of marginalisation? And in Epilepsy12, as we're trying to connect with healthcare records, we've been interested in this loop of data and whether we can do something that helps data flow, not just for the purpose of the audit, but to join the data up to serve other functions. So this has been a bit of a circle that we badged and shown in a number of years. So this idea of could we create a common core data set that then can flow between different registries, apps, dashboards, tools to help not just us as professionals, but patients and young people themselves. So the new platform that we've built has been built in faith to be a connected platform to pull from this loop of data. And we've been doing a project with the Professionals Record Standards body for the last couple of years to try and work out what this data standard should look like. So we're trying to do the building blocks for a connected future. And just to give you an update on where this is at, so we started it in 2022, we've gone UK-wide, we're doing adults with children, and we've decided we need to do this for the whole of health with epilepsy in whole health and do it for whole lifetime. It was funded by Epilepsy12 to start off with, but now has been jumped on by NHS England to get us over the line, so they're funding the latter phases of this. And it's a 6-stage cycle which we're co-creating with multiple stakeholders, and we're trying to disrupt, I suppose, the vendor landscape, so do something that is for all vendors in the complex digital landscape. And we're hoping that by creating a common data set, we can potentially help interoperability, and each of us will be able to think about if the data can flow, how that might help certain things we struggle with. And this is the 6 cheese wheel. And we're just coming to the end of stage 2. So we've already produced a draft data standard in 2024. There's a new one that's about to come out, and we're in the phase where we're beginning to build the technical spec for it and then go to piloting with vendors and then for full rollout. So it's just beginning to get teeth. And we've built a data model that has all the different things that might form part of the data requirements for someone with epilepsy through their life time. And the bits in green at the right show the bits we've had to do that are new, really. So we've had to particularly focus on outcome data and formulation data. That which makes up someone's epilepsy is multidimensional, and the current data standards don't really do that well. And then the yellow baskets show those bits in the health record we've had to tweak a bit to make it work for those with epilepsy. And I'm trying to think of it as an octopus with lots of tentacles. And if data's stored in a structured way and it has a home that serves the whole NHS, then you can have really useful things that go into that common space. So all the different things we're used to putting in forms can all flow into a common space. And then that same data can serve all the different things we often try and pull out of that data space. And often we're the middle person, or the patient is moving data from one place to another. But if we can centralize that data and require flow, then there's loads of time saving and value to be had here, and particularly for epilepsy, which is increasingly moving to wearables, implantables, digital video. The whole world of epilepsy is highly suitable for this type of joined up data flow, and that's just thinking about patient care, let alone the value of audit and research and policy setting. So in conclusion, I think there's lots of improvement to see. It's a difficult time for the NHS, and it's a difficult time in the world for all sorts of reasons, but there's stuff to be pleased about that we've been involved with, and it's credit to all of us in this space for driving those changes over the last 15 years. There's definitely signal there. There's things that are a bit stuck, but I'm hopeful that we can understand those and unlock those in the mix. I think increasingly over the next 5-10 years, we're going to be looking at individual attributes and how personalised care looks and what the enablers are for different types of people with different types of epilepsy. So thank you. Continue to take part, find ways to take part, think about job planning, how that should look for those of you who are professionals in this space. Think about how we can unblock flow for those who need complex support, and we need to unlock connections around mental health. We're going to, with Epilepsy12, try and grow our ambition towards mapping to other data elements, and this work around interoperability is really only just started. But you can imagine how big data looks with what we've got already, but the future of big data is going to be way beyond what we can imagine now. So we need to do some of the heavy lifting towards that. So thank you to everyone. There's too many people to list, but there's so many people take part in this journey. Thank you to each and every one of you. So let's knit those good connections and let's get them into the real world, not just into the abstract world. Let's get real octopuses in real high streets. Thank you.
Thank you very much, Colin and Niky. I am told that we have time for one question, so I shall look within the room.
I think looking at especially specialist nurses, but other aspects that are slowly improving, I think my concern, and I'm sure is a lot of people, is the people who are not actually entering Epilepsy12 at the moment. Is that because if they did enter, would that show even a worse outcome, if you know what I mean? And how can we as networks and conversations and things encourage people to do Epilepsy12? I know that the outlier kind of letter to the chief exec of our hospital has upped the game on them saying, we will give you a bit more nursing time if you do Epilepsy12. So potentially that might help. But are there any other ways that we can help to get people doing it?
Well, our third outlier was non-participation. So this the first year we sort of threw that into the mix, and obviously some services need help to take part, and we probably all do. And I suspect our data's skewed to the ones who are doing well, and the ones who are really struggling are struggling, and they're struggling to do the audit. So definitely needs to be resource for those to help all of us participate. But it's not as difficult as you think. It's quite easy to register. It's quite easy to do the organisational audit. You can get started with a few patients 1 year, and then hopefully the signal will draw you in, so you can begin to create a story for improvement locally, get yourself on the map, and then the numbers will pull you in. That's the idea. So, yeah, but there's a lot of work. We want full participation from everyone. You don't have to put every child in with epilepsy. You need to put in some enough for it to be useful. You can put every child in, and we're trying to build the dashboard so it's useful for whole caseload management, as Niky demonstrated. But yeah, get started, get yourself seen. Invisibility is a massive problem in epilepsy, not just for the young people and the stigma, but for the data and the case for change. So this data has definitely got a place to play in that transformation.
Thank you very much, Colin. Thank you, Niky. Another round of applause, please.
Sorry, just for the people online, we appreciate there's been quite a lot of questions have come in which we haven't had time to answer. But I think a lot of them definitely, if you can take the time to look at the methodology document that is available on the Epilepsy12, I think that will provide a lot of kind of answers to some of the questions. And Salima has very kindly said that if you do have any further questions, feel free to email the Epilepsy12 mailbox, and we'll be happy to, help you work through any queries. Thanks.
Thanks, Anjali.